and this is on gender and equity considerations in cataract surgery. Dr. Isra Hussain is going to be our presenter, and she's going to present a body of work. She's going to present some literature and also some body of work. The impact of gender and socioeconomic status on cataract surgery, the need for more equitable approaches to eye care delivery. Isra has been one of our research fellows. She has done a great job. She's a University of Toronto medicine grad, but also has a master's in this area. And she's going to be a resident next year in Halifax. And I'm hopeful that she will continue working on these types of issues as a trainee and then also as a clinician and researcher in her career. We've also added a few panelists, some of which may come and go because they have competing demands, important retina meetings, and probably other things going on. Nupra Bakshi is a well-known clinician, assistant professor at the University of Toronto, who has worked in this area. We also have Dr. Radha Kohli, also one of our clinicians, who has worked in this area, and both of them have been very thoughtful in thinking through some of the equity issues and helping us at a faculty development level as well to think through some of these. And yes, Laura Rosello, we've successfully promoted her as well. So thank you, Laura, for joining us, ophthalmologists as we work. Laura has been instrumental, so on that previous project and also what you're going to see here. She is one of our scientists at the Institute for Better Health at Trillium, but really has been a downtown University of Toronto researcher for some time. She's the principal investigator and scientific director of the Population Health Analytics Lab and an associate professor at the Dalai Lama School of Public Health, and incredible speaker, incredible researcher, collaborator. It's been an honor to be able to work with her a little bit, and hopefully we can do more in the future. And then Tina as well. She's been here. She's contributed earlier. She is a part-time resident currently because she's doing her PhD in areas related to this, a lot of big data research, a lot of equity research. She is going to have a fantastic career helping us through a variety of issues in ophthalmology. I'm very excited to see how her career is going to unfold. So Isra, why don't you take it away for our last talk, and then hopefully we can still have some discussions and finish reasonably on time.
Sounds good. Thank you, Dr. Schlenker. I'm just going to share my slides right now. Can everyone see those okay?
Yeah, it's great.
Perfect. Okay, so thank you for the kind introduction, and congrats to Dr. Schlenker, Diana, and the team for this awesome meeting. These are some really topical, important issues, and thank you for giving me the opportunity to talk about something I'm really passionate about, and that's equity. And today I'm going to be talking about equity within cataract surgery specifically. I don't have any financial disclosures, and I wanted to start off with a few questions just to get everybody primed for the topic and get everybody thinking about this issue. So the first question is, the disability adjusted life years related to cataract is greatest for either men in high income countries, men in low income countries, women in high income countries, or women in low income countries? And we did great on this one, which is awesome. We're going to go into a little bit more depth on the topic in just a moment. Next question, which of the following measures of health inequity consider differences across the full distribution of the population rather than just looking at the extremes? Either the slope index of inequality, relative ranges, or the relative index of inequality, or both the slope index of inequality and the relative index of inequality. Great, so I'm going to explain some of these metrics a little more, which are ones that we used in our study. And the last question is, based on the data from a large hospital in Ontario, the relative decrease in cataract surgery volumes before and after the COVID-19 pandemic was greater among women compared to men, greater among men compared to women, greater among the most socioeconomically deprived group compared to the least socioeconomically deprived group, or it was similar between the least and most socioeconomically deprived groups. So we're a little bit split on this one. So I'll go into the data from our study in more detail and explain it a little bit more later on in the presentation. Okay, so more broadly, my objectives for my presentation are the following. By the end of the talk, I really hope that we gain a greater appreciation for the burden of eye disease, specifically cataract, and how social determinants really impact this burden of disease. I hope we're also able to gain a greater understanding of what's out there in terms of the evidence related to cataract surgery utilization based on two main domains, and that is gender and socioeconomic status. And I'm going to go through this based on the literature, but also go through the study that we did at IBH. And then finally, by the end, I hope we're all able to recognize that there's a tremendous opportunity here to close the inequity gap by the implementation of real-world strategies. And I really look forward to discussing these ideas and thoughts with the panel afterwards. So let's get right into it. How big is this issue? So globally, 2.2 billion people have vision impairment, and at least 1 billion of those people have vision impairment that could have been addressed and prevented or is yet to be addressed. 65.2 million are due to cataract. And these numbers are probably an underestimation due to the lack of availability of data regarding the met and unmet eye care needs. And this is an issue that's only getting worse with our growing population, our aging population, and more urbanization. And we know that vision loss and access to healthcare is not born equal, with a lot of social determinants impacting these factors. The burden of eye disease is greater in low to middle income countries and for underserviced populations like rural communities, people living in low income households, women, older adults, people living with disabilities, ethnic minorities, and Indigenous peoples. Now, all of these factors are really important and greatly impact both the burden of disease and access to healthcare and eye care specifically. But for the purposes of this presentation, I'm going to focus mostly on socioeconomic status and gender, mostly due to the availability of data out there. But I do want to take a moment to acknowledge the complexity here, that all of these factors do impact burden of disease and access to healthcare, and many of them interact together. And the breadth of intersectionality is certainly not reflected in the current literature, and that's something that we need to consider as I go through this presentation, but also through our discussion later on. So let's go into what the data says. So in terms of the burden of cataract surgery globally and the impact of sex, these figures were taken from a paper that was published in JAMA Ophthalmology in 2018. And they looked at the burden of disease using disability-adjusted life years. Disability-adjusted life years are the years lost due to ill health, disability, or early death. And so the higher the disability-adjusted life years, the higher the burden of disease. We can see on the first figure to the left that since 1990, there has been a difference in the burden of disease between both sexes, with a greater burden of disease in women compared to men. And this trend has stayed fairly consistent up to 2015. Then when the authors adjusted for population growth and for age, as you can see in the second figure to the right, that there was actually an improvement in burden of disease or disability adjusted life years from 1995 through to 2015 in both sexes. And this probably speaks to how we're able to handle cataracts and cataract treatments. However, the difference between the two sexes still persists. So the inequity gap gap has not really changed or improved much. Now, looking at the socioeconomic impact of cataract surgery, cataract burden, these two figures were also taken from the same paper, and they looked at socioeconomic status on a national level using HDI, which is the Human Development Index. And in the figure to the left, you can see that in countries with a higher socioeconomic status, there was a greater burden of disease compared to countries with a higher socioeconomic status. When you look at the figure to the right, there is a greater difference between sexes in lower income countries or countries with a lower socioeconomic status compared to those with a higher socioeconomic status. So that kind of speaks a little bit to the intersectionality there, that not only is the socioeconomic status important, but the gap between genders also increases in these lower socioeconomic status countries. So what actually leads to this imbalance? As it pertains to gender or sex, this difference is likely due to a number of different factors, including demographic factors. Women tend to have longer life expectancies, and this could also contribute. But because these trends still persist, even with age standardization, this suggests that a lot of social factors are probably contributing. Things like cultural differences, literacy rates, transportation, awareness, these are all factors that are cited in the literature and things that are important to consider when addressing inequity. So now hopefully I've convinced you that this is an important and really big issue that's impacted by socioeconomic status and gender. So now let's get into actual cataract surgery and cataract surgery utilization in relation to gender and socioeconomic status. So first, starting with gender, and before I go on to talk about this, many of the papers published do refer to gender, but they look at this dichotomously, men and women. So at times they're probably more referring to sex than they are gender. This figure that is shown to your left here was taken from the Lancet Global Commission for Global Eye Health, and they were able to produce this figure using RAB databases, which is the Rapid Assessment for Avoidable Blindness databases from 20 different countries across 20 years. And they were able to disaggregate the data based on a number of different variables. Here in this figure at the top, it's disaggregated based on region, and then on the bottom, it's disaggregated based on sex. So you can see at the top in the figure in green that high income countries have a greater effective cataract surgery coverage compared to lower income countries. And the greatest difference is seen between sub-Saharan Africa and high income countries. Now, when we further disaggregate the data based on sex, we can see that women consistently have a lower effective cataract surgery coverage compared to men, and this is consistent across all regions. This was a study, a systematic review and a meta-analysis that was actually published this year that looked at studies exploring the association of gender with the utilization of cataract surgical services. And they pooled 13 different studies and found a statistically significant association between gender and the probability of utilizing cataract surgical services, with women being 0.76 times less likely to use cataract surgical services compared to men. But I do want to note in these studies, there's high levels of heterogeneity, so we have to kind of take it with a grain of salt. Now, these are other figures that were also taken from the Lancet Global Commission, and these I think demonstrate really nicely, again, the idea of intersectionality between socioeconomic status as well as gender. These are two figures representing the effective cataract surgical coverage in Nigeria and Sri Lanka based on gender, marital status, and the place of residence. And we know that marital status, including the place of residence, do inform things like socioeconomic status. And we can see in both countries that women have lower effective cataract surgical coverage compared to men, but this becomes even lower when they're widowed and living in rural areas. So now looking at inequity in waiting for cataract surgery, this study was out of Sweden and one of the very few studies that were set in high income countries, as most of the studies are in the setting of low to middle income countries. And this study found that there were statistically significant longer wait times amongst female patients or women patients compared to men, higher wait times in low income patients and those with lower education. Now, these are wait times that are longer by just a few days, so they're probably not really clinically significant, but these trends are still important. You can see that there was a paucity of data in high-income countries, and this kind of brings us to our study that was done with IBH, and we looked at the trends of cataract surgery volumes before and after the pandemic from an equity perspective, with a real interest at looking at these variables like socioeconomic status and sex, as well as age as it pertains to cataract surgery volumes. And I do want to acknowledge the entire team that was a part of creating this data and putting all of these figures forward. So the purpose of this study was really to examine cataract surgical volumes according to area-based socioeconomic status before and after the pandemic from a large hospital in Ontario. It was a single center retrospective cohort study. And we included patients who received cataract surgery between April 2019, just before the pandemic, and to December 2021, after the pandemic. And each patient was linked to a deprivation quintile to indicate socioeconomic status using the Ontario Marginalization Index. And all comparisons were made based on fiscal years. And this worked out nicely because the fiscal years were between April and March. So in comparing 2019 to 2020, the pandemic, if we remember, started in March 2020, which was just at the start of that fiscal year. So it made for a nice comparison of pre-pandemic years versus during pandemic to post-pandemic years. So I want to talk about the data sources a little bit. So this data was taken from the hospital. So this was health service volume data, and it included patient sex, age, postal code, and cataract surgical date. Using now this kind of data, we grouped the patient ages into patient ranges, and the patient postal codes were converted into census dissemination area using the Statistics Canada postal code conversion file. And then the DAs were then used to merge the data with the Ontario Marginalization Index to link each patient to a marginalization or deprivation quintile from Q1 to Q5, with Q1 being the least socioeconomically deprived group and Q5 being the most socioeconomically deprived group. And this metric was informed by income, education, and employment rates in that area. I want to spend a little bit of time talking about the inequity measures that were used here, which I learned a lot about from Dr. Rosella, so I'm really happy that she's here today. And those are the relative index of inequality and the slope index of inequality. And these two metrics are generated using linear regression model, and they allow us to compare the most socioeconomically deprived group to the least socioeconomically deprived group, but use the full range, full distribution of the population. So they are able to compare Q1 all the way through to Q5 instead of just looking at the extremes, like for example, a range would look at Q1 versus Q5, but ignore Q2, Q3, and Q4. So this gives us more accurate representation of what the degree of inequity actually is. So now looking at the results, cataract surgery volume did decrease since the pandemic. And you can see in the figure here that pre-pandemic in 2019, the cataract surgery volume was about 6,000, and this decreased to 3,232 at the heightened phase of the pandemic. So this was a decrease of 46%. During the same time period, there was the greatest decrease by volume in the age group of 70 to 79 years old, and patients who were 80 to 89 had the greatest relative decrease. In this study, we didn't really identify any differences based on sex in terms of the relative decrease of cases before and after the pandemic. And all of these trends were maintained through to the next year. Here we can see the percentage of surgeries based on deprivation quintile, and we can see that there was a decrease across all deprivation quintiles from before the pandemic to after the pandemic. But we can see that across all years, the most socioeconomically deprived group, which is Q5, had a much lower percent of surgeries represented in the total percent of surgeries. So they had about 12% of surgeries performed in this group. And in the highest the least socioeconomically deprived group, they represented about 20% of the total surgeries performed. And this was, again, consistent. So in other words, there are more surgeries performed for the least socioeconomically deprived group compared to the most socioeconomically deprived group. And we can see that these trends are maintained and nicely represented in this figure. The red line is Q5, which is the most socioeconomically deprived group. And you can see that they consistently, across all points before, during, and after the pandemic, had lower cataract surgery volumes compared to all other groups. Now, the surgical volumes in each group did, as you can see in the percent difference, decrease before and after the pandemic to a very similar extent across deprivation quintiles. However, the important piece is that they still have lower cataract surgery volumes. We can see the SII and the RRI values represented here demonstrate that there is inequity seen across all of the groups. So there are more surgeries performed in the least socioeconomically deprived groups. And although the SII and the RRI improved slightly post-pandemic, it still represents inequity. So this is really an opportunity to intervene here as we plan our post-pandemic recovery, and as we're thinking about surgical volumes and wait times and the backlog that still exists post-pandemic. We need to really start to think about equity as a part of this plan. So here, as a part of the study, because this was linked to postal codes, the hospital was able to identify which postal codes around the hospital had the greatest number of patients with in the most socioeconomically deprived groups. And this will help really aid in targeting interventions to these communities and allow the hospital to reach out to these communities with programs to help close the gap. So the key takeaways here are that women and patients with lower socioeconomic backgrounds have a greater burden of disease and poorer access to care based on the current literature. However, more data is on social determinants, and cataract service delivery is from low to middle income countries. Post-pandemic recovery of surgical volumes offers an opportunity to close the gap between the least and most socioeconomically deprived groups. So now we really have to start to think about intervention and how we can close this gap. Community outreach, vision screening has been shown to increase equity amongst groups like women, marginalized communities, and older adults. We also need to continue research in collecting data about equity. Measuring equity in service provision is really important, so we can disaggregate this data and continue to monitor the effect of various socioeconomic variables. And finally, we need to incorporate standardized ways to actually evaluate socioeconomic status, as we were able to do in this study. So this is just a reminder that of the 17 Sustainable Development Goals that were posed by the UN to create a better world by 2030. And I want to remind everyone that eye care delivery has to be on the agenda and will help us achieve some of these goals. And in particular, I've highlighted gender equity and reduced inequalities in general today. Thank you.
Great. Thank you so much, Isra. Thank you for putting that together. This is a little bit, new, I think, for for many of us, many in the audience, but hopefully this is the way of the future. And I, for one, was surprised and disappointed to see that lowest stratum. You know, we're proud as Canadians that we'd like to think we have a reasonably universal healthcare system, and we're also talking about a fairly well-serviced area. We're talking about Trillium. You know, it's Mississauga. It's basically one of our, you know, higher service areas, and it's still showing these disparities, which I think is concerning, again, assuming we measure it properly and doing it all well. So Laura, I know, I think you do have to run, but do you have any comments or thoughts?
Yeah, I'll just say, you know, really nicely presented. Just for context, you know, we are monitoring these inequities across a number of hospital services, and I've been looking at these across Ontario for, you know, 15 or 20 years. And I'll just emphasize that the inequities seen here are seen in many other services in our healthcare system. And so it's surprising for the reasons you said, but also not surprising, and just really reflects some systemic issues in our system at large. So it's not just ophthalmology. I wanted to make that point. And also to say, you know, this is just the first step, you know, just to have a look, to understand the patterns, and then the work comes with, well, how do we start actually closing the gap? And that involves multiple strategies. And I know your team and many here have been really thinking about the interventions, which I think is so exciting. So, you know, looking at the data is important, but the interventions and acting on them is really where we need action. And I'm really pleased to hear already so many ideas around this.
Great. Well, thank you for that comment, and said all your work, and that we're really trying to bring this into the scientific realm, something that's very, very hard to characterize, analyze, report, and then intervene on. So I really appreciate all of your work on this, and hopefully we can do more. Radha, you have your hand up.
Yeah, great presentation and work, Isra. Congratulations to you and the whole team. I was going to say, you know, looking at, of course, the inequities of patients is very important, but, you know, we've just done a study. We just are putting the paper together looking at sex disparities in OR distribution. And this has been self-reported, but based on OMA billing data, we found that there's a discrepancy even between females versus male OR time, access to OR time, or days given. And so women on average, or I should say females in Ontario, you know, there's 195 comprehensive surgeons. We didn't include any subspecialists who do cataract surgery, get on average 12 days less per year. So surgical volumes are the same, but female ophthalmology cataract surgeons get a day less a month in OR access. So these inequities are everywhere. Like if you look 360, who the surgeons, how much time they're getting in the OR compared to their male counterparts, what's happening to patients. It's sort of a global problem. And I think if we can find out why, for instance, this OR distribution discrepancy exists between sexes, you know, that can also help perhaps in dealing with inequities in patients also, because we do know that females tend to see more female patients and more complex patients, and often more younger patients also. So we need to equalize our OR distribution too. And actually how OR is distributed is a real mystery. There's no data on it and no metrics. Like how do we know, why does someone get 2 days and someone else get 1 day? So I'm going off topic, but the discrepancies exist in many realms.
Yes, thank you. I agree, and that's not something we've studied, but it's probably it's definitely a piece of the puzzle, and possibly also, as you alluded to, part of the solution. Tina, and then Nupra.
Excellent talks by everyone. I've learned so much, and it's really nice to see that this information is actually being discussed. And I want to also highlight that collecting this information is really the first step. We looked at the wait time information system for all of Ontario, and looking at the disparities between wait times for patients. Our wait times have been going up since 2010, about 5 days increase in wait times a year. And obviously this was exaggerated during the pandemic. When looking at the two sexes, so males and females, and this is how it's been recorded in the wait time information system in all of Ontario, females tend to wait anywhere between 4 to 6 days longer for cataract surgery compared to males. And this is consistent across all regions in all of Ontario, as well as despite the priority level. So whether they're high priority, low priority cataract surgery at the time that they're being registered into the system. So this was a really interesting observation, which is aligned with what was presented by Isra by the Swedish National Registry for Cataract Surgery as well. And they found the same thing, that females tend to wait longer than males. And then when you look at other factors, which unfortunately wait time information system in Ontario doesn't have this information, but when you look at income status, rural location, geographic location, other kind of disparities as well, socioeconomic factors, that intersection of those factors together combined with being female exaggerates the delays in cataract surgery. And then when you're looking at beyond actually ophthalmology or even beyond cataract surgery and retinal detachment surgery, there's been studies that have shown females tend to wait longer. And then beyond ophthalmology as well, and other surgeries, bariatric surgery, trauma surgery, females tend to wait longer for any of those surgeries. So just an interesting observation to make note of. When you looked at the pandemic period in particular, the wait time disparity between males and females actually increased by 10-fold. So there was a factor about the pandemic, potentially the burden that was placed on females in terms of taking time off from work or caring for others, that those disparities in wait time actually was much, much more increased by 10 times. So again, factors to consider. I'll just go back quickly to some of the other comments and thoughts that were mentioned about rural and geographic location. We've seen in diabetic retinopathy screening that sometimes actually patients that live in rural areas are more likely to be screened compared to urban areas. And I think that is counterintuitive, but when you think about density and the ratio of patients to eye care providers, it's actually an important consideration as well, because sometimes the number of eye care providers may be higher in urban areas, but actually the ratio of patients to the eye care provider may be much higher as well. So those are things to consider.
Thank you. I agree. You know, I think Isra said it and you said, 1 + 1 = 3 for a lot of these things, unfortunately, two-hit hypothesis. And yeah, the rural versus urban is also, interesting. I do think sometimes we say, oh, the cities are fine. Well, the cities have a lot of the 1 + 1 = 3, and there's just, people move to cities. They immigrate to Canada. They may end up in a rural area, but it seems like people continue to go to the cities. So I agree that we can't just always say it's rural. It's much more complicated than that. Nupra, go ahead.
Thank you so much, Isra, for that presentation and trying to put together a summary of a very complex topic and the work that your whole team has done. I think it's really important that we're discussing this. As you were speaking, I was reflecting on what is the physician role in this and how do we perpetuate perhaps the inequity? And, is there a part that has to do with unconscious bias in how we book patients for surgery when we make that decision of when it is time for surgery? Or, I'm just curious, I don't know if any of the data showed that. And I think either way, though, it is something important to reflect on. And as to Radha's point as well, perhaps the fact that there are fewer women surgeons and we get less OR time, how does that also play into that aspect of perpetuating this equity? But I think perhaps something that we can also take away is to really think about that actively when we're seeing our patients and we're making those decisions on surgery, and to kind of check any potential bias in the moment and just be aware of it. Are we treating these patients exactly the same based on their eye disease and what the level of their cataract is or their comorbid eye disease, rather than thinking of all of the other potential factors when we make that decision? And I think that that's also a really important aspect that, is hard to study, but I think really important to be aware of.
Yes, thank you. Couldn't agree more. Ike.
Yeah, I mean, such great comments and such great topics. And I certainly have a lot to learn in this area. And thanks, Esther, for presenting it. And thanks to Trillium for really putting that data together. It's interesting to see that a lot of this is driven by socioeconomic deprivation, as you showed, as the primary driver in inequity in terms of surgical rates in our area. And when you look at those postal codes and you look at them and you map them out to ethnicity, you see that most of those postal codes actually have a higher preponderance of racialized minorities. And so the theory being that one of the drivers for this is that very issue is also the racial aspect of care. And that's an area that perhaps doesn't get as much attention, although we know that's an important driver. And this may be related to, new immigrants. It may be related to translational issues, communication issues, all of these things that have to be considered. I think it's a great way to kind of finish this symposium because we're talking about appropriateness and prioritization. And if we don't talk about the way we communicate, the way that culturally we don't adapt to different cultures and how we look at healthcare, then we're going to fail our vulnerable patients that we see in this particular area. So thanks for sharing that. I think we just want to highlight those areas that are very important. I think everyone's made some great points. And I'm excited to see where this goes as far as particular intervention, which again, I'll bring back to the point that we can't forget our primary eye care providers. Those are the gatekeepers for our patients. And any strategy needs to incorporate their positions and their facilities, and what they bring to the table as well, not just us as surgeons. In fact, that may be a more important aspect of that delivery.
Yes, thank you. Thank you. Conrad, I see you're still there. You're burning the midnight oil again. You're listening to us Canadians from Australia. There's some similarities. How are we doing? Could we be doing better? Is Australia doing better? Can we learn something?
Well, the midnight oil was a while ago. You can learn that. It's amazing how similar things are. It really is. And look, Isra's talk using the Global Vision Database information shows how global these inequities are. But getting to Australia and Canada, they are similar countries in that you have a large area, large states or provinces with one or two major cities. So I think we have all the same regional issues. We have the same or very similar problems with barriers to cataract surgery amongst the Indigenous. But in the cities, as the data shows, we have exactly the same issues with social deprivation, socially deprived groups, which again are dominated by ethnic minorities, including the English, I'll say. Just not accessing healthcare. But my impression of this is it's just more socially deprived people, generally less well educated, much less able to advocate for themselves, much less able to negotiate any health system. I mean, we think maybe getting access to cataract surgery is a relatively easy thing. There are optometrists everywhere in both our countries. You can get an eye examination relatively easily and inexpensively and get referred for cataract surgery. So we might think that's simple, but clearly it isn't, because if you're less financially sound, less educated, you simply don't access care as readily, and you just don't know how to find your way through and get the treatments you need. I'm not sure what we can do at the eye care coalface. It's a much deeper, social population level a problem. I think I'm not saying we should ignore it, but I think this is just so embedded in society and for all of healthcare.
Yes, well, thank you. I don't know if it's reassuring or concerning that you guys are, having similar issues, but hopefully that's why, we can have symposiums like that where we do try to work together. I always personally, I think about, I'm going to go into the glaucoma space, acute angle closure glaucoma patients. And I have some acute angle closure glaucoma patients that the second that they are having symptoms, they are at the emergency department. And then I have others who are like, well, it was painful, but I had to cook for this gathering. And then I had to go do this, and then I had to do that. And yeah, the pain, I didn't really sleep for a few days. But this was kind of when someone could bring me, and I didn't really know where to go. So I went to this peripheral hospital and then I got sent to you. You know, and it's just, I think it just illustrates all of these cultural, gender, you know, complex factors that you know, someone goes from maybe being treated to their angle-closure glaucoma to me doing, you know, a large surgery and then really having a poor outcome because it's been going on for so long. So just an acute example in my own experience. And I think there's many, I think all of us too, when we see those really dense cataracts and you start answering the question, Diane is actually asking those very patients who present with, you know, blinding cataracts, you know, where have you been? What have you been doing? You know, any reason why you haven't seen anybody? As Conrad said, you'd think it would be easy, but it's clearly not. So these are our challenges, and I really want to appreciate. I really appreciate everyone